Hello, everyone.
Hello.
Hello, hello.
Hello, Antonio.
Hello. How are you?
I'm good. How are you?
Fine. Fine. Fine.
Hello, Elizabeth.
Hello, darling. How are you?
I'm good. How are you?
Yes, I'm okay. Thank you.
Yeah, it's like we have come in a bit early to prepare
No share screen, just press
while we wait for everybody.
Oh, okay.
Yeah.
Yes, exactly. Yeah. Daniela, wait, come.
It's been a
I
busy,
want to upload the documents on the side.
busy weekend.
It is. It's quite busy, and literally, I've just been preparing my work this morning as well to add on what I want to do.
Can you see anything there? No. Hello, Doctor. Hello, Dr. Whitley. How are you?
Good morning. How are you?
I'm good. I'm going to put my camera on. Let me see here. We are on a bit early, so maybe we're just waiting for people to tune in. Why can fail to start a video camera? Please select another video. What's happening? So yeah, there we are. Antonio, meet Dr. Kim Whitley.
Nice to meet you, Doctor.
Nice to meet you.
She's gonna share a lot of interesting information for us. I'm actually excited that you joined us, and I look so much forward to it. We really needed this session. And when I heard you speak about it at the coalition meeting, I was really so happy because it was as if it was fate, because we were already thinking about it since December, and we said we have to do something about the traits. So, and then to see that you're doing it's amazing. So I hope it's gonna be a good session.
I'm sure it will be.
Antonio, I will let you introduce yourself. Maybe we are just catching up at the moment.
Yes.
Wait for people.
Yeah. My name is Antonio Arenas. I'm from Spain. I recently we founded the new association, Scale Cells, here in Spain.
Nice.
Only we have 28 members with this DC here in Spain. Although in Spain exists more people than origin from Africa. But in this moment we have to create. We have it's recently, and with this pandemic, it's very difficult to increase the the association to give the knowledge about the association to the different partners. No.
Yeah.
For me, it's a pleasure to join to the skill cells in this SFI.
Antonio.
Yeah.
Antonio is a patient, but it's sometimes people, when he says he's a patient, they don't believe. And yet,
Yes.
Same thing here. Yes,
yeah.
the same thing in the US.
That's not right, because we are trying to preach that this is a universal condition that can affect anyone, and yet people, when those that are of a lighter skin or white skin, when they come out, people don't believe them. So it's really strange, isn't it?
Yes, it's very really strange, because when I had in a meeting with other patients, I have my brother and me. I only we have the only white people in this session. Yes, it's very difficult to find white people with this disease, but this is a disease because in Spain the Marroquí were living many years, and the genetic is here in the Spain.
Change though, isn't it?
Is but I don't have many problems with this disease, because I normally I do a normal life. I am an engineer, a food engineer. I work in a company, But sometimes I have a problem, like other people with ADC.
It's interesting. At least you're still able to do something and live a normal life, isn't it?
Yeah.
Yeah. Hello, Dr. Tomia. You're welcome. I think you're muted. Yeah.
Okay.
Yeah, you're okay now.
Is that better? Yeah.
Yeah, it's better.
Hello, everyone.
Hello, nice to meet you finally.
Yes, I finally got negative undetected. I'm all good now.
Oh, that's very good. Oh,
Yes,
that's
yes.
very good. It's quite a stressful period when you finally hear that you're positive, and then all these symptoms, and you go through them. But there are people who still don't believe that COVID is real. So for you to, so for
I know it's real.
say it, they are like, are you sure? So
Yeah.
I'm really glad. It's nice to see you happy and okay, smiling. So Dr. Whitley, please, I just want to introduce you to Dr. Tomia Austin. And I think she runs the As One Foundation, mainly campaigning for sickle cell trait, isn't it?
Yes,
We've met at SCDAA.
I thought so. Yes, wonderful to see you again.
Very nice to see you again, Dr. Smith-Whitley. Yes.
So I don't know. People are very slow today. We give them. Okay, they still have the 7 minutes, right? I'm just going to let everybody like catch up and get to know each other. I'm gonna pop out for a minute to grab my diary, if that's okay. Thank you.
Okay.
Thanks.
I saw you last in September with Jamel Hill and all of the.
Oh, yes, right? I'm so excited to see that there's such energy. Not that I didn't know that there was an energy already around sickle cell trait, but now to see it finally get the attention at the national level, I think is very important. I was very pleased to participate in that panel.
Yeah, that was really, really great. And we just need more and more and more and more. So thank you for facilitating that. I've followed the organization ever since, and hopefully we can get some more movement going because those athletes just have an unbelievable draw, you know.
Right? What a powerful voice.
Yes, big voices there. So, and all of them are trait warriors, as we call them, and have something to say, and folks will listen because football is sexy. So
yes.
You know,
we're definitely gonna keep in close. Good day. How are you?
Hello.
I'm fine. My name is Irene. I work with Sickle Cell. I work with Lola.
Oh, very nice to meet
Very
you.
nice to meet you, Miss Irene.
Nice to meet you too.
And hello, everyone else. I just, apologies to be rude.
Sorry?
I'm saying hello to everyone else.
Okay.
Hello, Tomia.
Oh. Where is my book?
Will this be live on the European Sickle Cell Federation Facebook page? Does anyone know?
No.
Okay.
Oh, hello, hello. Come on, people.
Laura, is it live on the Facebook page?
No, that's something I don't know how to do.
Okay, no problem.
We can actually go through that if you know what to do. Do I go to? Okay, yeah, it says go live on Facebook. It seems I'll have to log into Facebook. Okay.
No, you don't. If you're in Zoom, you can just go live from Zoom.
Oh, okay. Jeez. Why is it saying I should log in though?
But select the page. Do you have multiple pages, or you can just select the European Sickle Cell Federation?
I have
Your personal page, probably.
it won't go. You know why? Because I don't even know my. You know when you've been using Facebook for long and you don't even know the password and everything anymore.
Yes, yes, yes.
Yeah. Oh God. I've seen how it could work, but I would need to find the login details. Hello, everyone. You're welcome. Welcome to this event. Konsi Bomono, the president, is actually meant to be hosting. I think she's just come in now. Hello, Konsi. Dr. Whitley, I'm going to make you a co-host so that you'll be able to share your slides as a co-host, right?
Yes,
Okay.
thank you.
It's like Konsi has gone off. Hello, everyone.
I'm here. I'm here.
Oh, there she is.
You don't see me. I see you.
How are you?
Fine. I'm getting there. It's better to say I'm getting there than saying I'm fine. I think so.
Good. Good.
Yeah.
We have Dr. Kim Smith Whitley is already here. She came before you. You're meant to be here before her. So we will charge you €100.
So nice to meet you.
Nice to meet you, everybody. Welcome, Rebecca. Welcome, Irene. Welcome. Oh, Elizabeth is here again. So she was here before you again. Consider that's another €20. Welcome, Palmyra. It's nice to meet you.
Thank you. Nice to meet you too.
Nice to meet you. You're welcome, Tessa. It's good to see you again.
From the US, nice to see you as well.
And we have Dr. Maisha, we have Jenica, where people have joined in. We have our own French representation, Dianaba, welcome. So welcome everybody.
Hi, Laura. Hi, everybody.
Hi, everyone. So I'm
Hello.
going to pass off to Konsi, but before I do, everybody that joins in, please, we keep our mics muted to allow clear communication for the speakers. And if you want to say something, you can raise your hand. I think that is somewhere where you go. I think, is it in participants or chat where you raise your hand or something like that? Yeah, so we will, the session I think is gonna go on with the host and the co-host are gonna introduce the federation. And then they will introduce the speaker, the first speaker, and between them, they'll be introducing the speakers. The speakers will speak for their minutes. I will be watching the clock, so I'm not gonna let anybody pass any minutes. I'm gonna be strict. And then the sickle cell trait sharing their personal experiences will also speak. Then we will have a huge discussion, because that's the most important part, is to have enough time for discussions, for questions, and so everybody will be happy. We are gonna keep it nice and smooth and clear. And yeah, that's it. So I won't take 3 minutes past. Consider you go.
Thank you. Thank you, Laura, and I'll try to do my best to pay all the funds, the fines that you have given me now. So anyway, thank you all for joining in this very important discussion on this webinar that we're going to have this evening, and also morning, I should say, because we have different time, how do you call it? Someone help? Timelines. Thank you. So I am the president for ESCF in Europe, and a few of my colleagues are members, and also people who are just interested in this subject are. I'm really, really happy to see you all. And this is a subject that I feel that it has been overdue. It should have been discussed many, many, many years ago. And I feel tackling it would be actually a way moving forward for even the sickle cell disease patients. So I just want to welcome you all. Antonio, do you have anything to add, or?
No, not for the moment. And thank you for your introduction. Yes, okay. Hello, everybody. If you don't know me, I introduce myself. My name is Antonio Arenas. I'm 44 years old. I'm the president of a Spanish Association of Sickle Cell Anemia. The name is SAFE. I'm also sick with the sickle. I have a patient too. And our association is newly created. It's only 6 months. And this year with the pandemic, we have a problem with the promoted the association in Spanish in Spain. In ASAFE, we are about 28 associations, represented 32 patients, because there are many parents with children. And for me, it's all. Thank you.
Back to you, Consi.
Yes, sorry for that. I think we can start the webinar now. And is it Dr. Kim that is first out? So Dr. Kim, the floor is yours.
Thank you, everyone. Good day. I hope everyone can see my slides. I'd like to start by thanking the organizers of this discussion, the ESCF, the European Sickle Cell Federation, and for their insight in choosing this topic for discussion today. Sickle cell trait occurs here in the US in 1 in 12 African-American newborns, but we know that there are only 3 million with sickle cell trait living in the US, but 300 million living with sickle cell trait worldwide. There are many differences that the sickle hemoglobin has led to conversations, not just in the clinical or medical manifestations, but the societal implications that have occurred throughout decades here in the US and worldwide. And although we know that there has been newfound attention to sickle cell disease, we know that the attention to sickle cell trait is lagging behind. Although the first individual with sickle cell disease was described here in the US in 1910, it wasn't until 1945 that sickle hemoglobin was actually discovered. And despite that, it took many, many decades to understand the difference between individuals living with sickle cell trait and individuals living with sickle cell disease. And it was with a lot of political initiation in the late 60s that led to the US government in 1972 initiating the Sickle Cell Anemia Control Act in order to get more research dedicated to sickle cell disease. And in a way, sickle cell trait went alongside that. Sickle cell trait is a health disparity. And by that, I mean that there has been an oversight in our attention to sickle cell trait, both at the societal level and the clinical level. There are many, many reasons, and I just would like to outline a few. First of all, when individuals with sickle cell trait are screened, often they don't know that they're being screened for sickle cell trait. And there's poor communication between the team that is doing the testing and the individual receiving the testing. Most often when we screen for sickle cell trait, we are also obligated, I think, ethically, to do good genetic counseling, to really explain the reasons why sickle cell trait would be important to that family. There's lack of guidelines about communication of the results and how to do genetic counseling. There's inappropriate testing employed, and that's a lot of the reasons why there's been so much confusion between the associations of complications between sickle cell trait and sickle cell disease. Also, there is a interest in the exercise-induced complications associated with sickle cell trait that's received popular attention here in the US through the National Collegiate Athletics Association. And I believe Dr. Austin will be talking more about that. And I think that that's important to point out. And then there are limited studies that really look at the link between sickle cell trait and medical issues. And I'll talk about why that is. And then there's a paucity, very few education programs on sickle cell trait and its associated complications. Here in the US, we just recently had a big strategic plan on the blueprint for sickle cell disease and what needs to be done in the next 1 to 10 years. And this group made it a point that sickle cell trait needs to be addressed as well as sickle cell disease. And that's because we really need to understand the full impact of sickle cell trait on individuals and society. So let's just start by when here in the US do we test for sickle cell trait or sickle cell disease? Well, part of the issue around testing for sickle cell trait comes because we are really looking for individuals with sickle cell disease, right? And so unfortunately, individuals with sickle cell trait may not get the full attention and explanation of the problems because many screening programs are set up to identify sickle cell disease. That's the case for the newborn screening program. For the screening program in athletes, they are looking for sickle cell trait, and I'll talk about why that is. We also here in the US have a recommendation to test in pregnancy so that we can better inform the expected parents about what their child may have. And then screening prior to the military is done in 2 branches here. And then we should also be testing when individuals come in with certain problems. We should be testing if they have a spleen problem. One of the athletes, a football player, was playing football at a high altitude and had problems with his spleen. When you have blood in your urine or hematuria, there's a rare cancer that's very aggressive in individuals with sickle cell trait called renal medullary carcinoma. And if individuals come in with that, we should test then. And then if somebody is hit in the eye, and they get a little bit of blood in the inside portion, individuals with sickle cell trait are predisposed to developing high pressures or glaucoma, and that can impact their vision. So when we're screening for sickle cell in the US, we really need to focus on what I believe is the true necessity of genetic counseling, but we also need to educate about those various complications. And we're trying in the US to get doctors to really, after newborn screening, to sit down, talk to the families about their results, put them in the medical record so those results follow that child across the lifespan and educate that child about the implications of sickle cell trait. So we have a big initiative here in the US to document, also to document about other hemoglobinopathy traits when combined with sickle, can be sickle cell disease. So to educate individuals with C trait, E trait, and beta thalassemia trait as well. I want to take a step back and also talk about one of the things that's very concerning, and that's the type of test that you do for sickle cell trait and sickle cell disease. All of these in bold are really, really good ways to separate out proteins and to diagnose individuals with not only sickle cell trait, but C trait. And in certain circumstances, we can even diagnose beta thalassemia trait. Unfortunately, here in the US, this solubility test where you actually take someone's blood, shake it up and see if you can get the sickle hemoglobin to precipitate so that they can see the results that way with trait, has been recommended for athletes because it's very cheap. But there are many false positive and negative results. So there's certain circumstances where they think that sickle hemoglobin is present when it's not, and other circumstances where they miss the sickle hemoglobin. So we're really trying to discourage the use of this test here in the US. Some people call it the shake test. Some people call it sickle dex. But we are really trying to discourage it being used for any kind of testing here in the US. And then it should never be used for genetic counseling, because you may say to someone when they test the shake and it's negative, oh, you are not at risk for having a child with sickle cell, when in fact, they may, because they could have C trait, beta thalassemia trait, or they could falsely be missing the sickle trait. So I do not recommend the shake test or solubility test. Then what is the issue, and why in 2021 do we not know all of the associated problems with sickle cell trait? Well, because the studies were not done well with screening protocols, and they were not done looking forward. They were always looking back, and that brings a lot of bias when you do that. I just wanted you all to see on this slide all of the different things that can be associated with sickle cell trait. You can see the kidney not only has this problem called the renal medullary carcinoma, which is that rare cancer, but individuals with sickle cell trait may not concentrate their urine well. They may need to get up multiple times in the middle of the night to use the bathroom. They can have blood in their urine. Blood in their urine can actually lead to obstruction and cause a major kidney problem. They can also have more problems with chronic kidney disease. And they can also have a problem when they break down muscle tissue. It can lead to having problems with the kidney. I talked about that condition in the spleen, where the spleen doesn't get enough oxygen, that's splenic infarct, and also clotting problems, venous thromboembolisms, deep vein thromboses, and PEs. I talked about that increased pressure in the eye, also that breakdown of muscle tissue, and something called exertion collapse associated with sickle cell trait. That's an exercise-induced problem. And then when individuals have diabetes, and they want to know whether or not the medications are working well for diabetes, if they use the standard test, a hemoglobin A1C, it can give them false results. I don't need to tell this audience that the reason that sickle cell trait gets a lot of attention is its protection from severe complications of malaria. There's a lot of myths around this. People with sickle cell trait feel like they don't need malaria prophylaxis. They absolutely do, because malaria is caused by different parasites, and falciparum is the only one that individuals may not get severe complications from. And individuals with sickle cell trait actually can get malaria. It's just that they do not get severe complications associated with malaria. Sickle cell trait and exercise is going to be addressed by Dr. Austin, but it is really, you can have sudden death on the field, and why individuals in the military and individuals playing sports, particularly football, are prone to that is under great debate here in the US. You can have unexplained sudden death, this breakdown of muscle tissue and cramping when they exercise hard, and also collapse on the field from this. We have been trying to advocate for good physical conditioning for athletes and military participants, warfighters, and athletes overall. And if you do good physical conditioning for everybody, there's really no need to identify those with trait. So in summary, I just want to reiterate that sickle cell trait is a disparity that we really need to pay attention to. We need to do better genetic counseling. We need to do more research. There's opportunities to keep databases on hemoglobinopathy trait so that we can actually do better research. We should be aware of how we communicate results to individuals in a compassionate and respectful pattern. We need to not use solubility testing. We need to document results so that we can educate individuals with trait across the lifespan. And this just shows the opportunities from birth to adulthood that we could actually educate. We need to dispel myths. Individuals with sickle cell trait can be blood and organ donors, and they need to understand that they are not excluded from that. These are all of the things that I mentioned that would be improved with better research. Not only medical research, but psychosocial research on how to communicate test results. This just summarizes all of the different things that I talked about. I shared my slides with Laura so she can share the slides with you. Here are good resources on the web at the CDC website and SCDAA. And the CDC actually has a toolkit that goes through all of the associations with sickle cell trait. And I will look forward to talking to you all later and answering any questions you may have. Thank you.
Thank you very much, Dr. Kim. I see Farron going like this, so that's a lot of things. So that was really, really a lot new for me, and I'm really happy to hear that. And now we're looking forward, or we're going to hear from Dr. Tuma Austin. So you're mute, you're on mute.
I have slides also, so yeah. Can I share my screen? Can you see my slides? Okay. Why isn't it getting bigger? Okay. So I am Dr. Tamia Austin, and I cannot tell you how happy I am to have the opportunity to not only share this information, which is certainly a personal and professional passion of mine, but to share this space with Dr. Smith-Whitley. I am a PhD, Dr. Whitley is an MD, and here in the United States, this sickle cell trait space is sparse, especially to have the supportive conversation around it. So I am thrilled and honored to be here to be able to share. I am the executive director of the As One Foundation, where our mission is to empower families globally, delivering life-saving sickle cell education. This young man in this picture established the As One Foundation in 2007 as a result of his story, his tragedy turned triumph story of living with sickle cell trait. He and his brother were born in the Bahamas. did not know they had sickle cell trait until after they had been living in the United States, were recruited nationally to play football, and ultimately decided to play at Florida State University, where they took their pre-participation physical, which is the only other mandated time outside of the newborn screening where testing is mandated here in the United States. And the situation around how they were tested, the motivations, created some barriers, but also ultimately led to Devon, the younger twin's death on February 26, 2001. So this is not only, this is very timely as we approach 20 years since losing Devon Darling to exertional sickling. He had been coached up to, your body is amazing, you'll pass out before you die. There was an association of water with weakness. And in those conditioning workouts, there's just prolonged physical activity with no breaks, to the point that if you did pass out, your teammates are carrying you through the excessive drills. And this is the benchmark to be a winning football team. And unfortunately, or fortunately, however you read it, they had won every game but one that year as true freshmen. So they were motivated to come back and show that they could go harder, longer, stronger. And going that hard without hydration, having vomited and passed out, cost Devon Darling his life. Devard would go on, and still, after much tumult and barriers, end up going to a totally different school, clean across the United States, and end up at Washington State. And with his brother's death, being a part of the starting of the NCAA screening, it was current at that time for Division I athletes only, Division I schools only, but subsequent deaths ended up making it for all divisions. But even though there has definitely been increased awareness and hopefully decrease in deaths and incidents, the deaths still do occur. And as Dr. Smith-Whitley said, as you will hear repeatedly, the education is key. The education is very, very important, because sickle cell trait deaths still remain the top, as they call it, non-traumatic killer of collegiate athletes here in the United States. And those are predominantly African Americans. This is just a few of these beautiful faces of young men and women, because sickle cell trait has taken female athletes, and it's not just reserved to football. As you see, Shanice Clark is a basketball player. These deaths have occurred and unfortunately continue. One good thing about 2020 is we haven't had as many documented, and Farron, who you will hear from, Farron Dozier, who is my partner in, I got to find another word, because this is not crime. This is not criminal what we're doing here, but we are in the trenches raising awareness. Us at the As One Foundation since 2007, I believe Farron has been at it. And we really are trying to turn the tide around sickle cell trait education, even though this seems to be a doom and gloom story. And I have to say, and it's not just reserved to college. These are high school and even younger athletes that are all documented, caused because of sickle cell trait exertion. We are raising awareness. We are helping and hopefully helping people understand what exertional sickling is and is not. And there is a difference. There's a major distinction. I saw Dr. Pasante on, and hopefully she'll be able to chime in and talk about the difference between the exertional sickling and heat stroke. Exertional sickling can happen in non-heat conditions. Sometimes cramps are misinterpreted as cramps, when in fact that is a trait crisis happening. There are so many myths, and one of the major is that this is something that only affects African Americans. And Based on this global conversation, we understand that this is not just something reserved to Americans. It is not purely benign. And as the newborn screenings go, when that letter is received by the parents, if it's received, because every state does not actually send a letter, it usually has a few bullets, something to the effect, you have sickle cell trait, there's nothing to worry about, live a normal life, just don't procreate with someone else with trait to avoid the 25% chance of birthing a child with disease, but very little, if anything, about the rare cancer, the exertion, and other things that can occur with sickle cell trait. Right now, the current conversation, the sickle cell trait conversation, is usually in one of three incidences. It's at diagnosis, when that young person is considering playing national collegiate athletic sports, and unfortunately, often when it's too late. That again, I'm referring to that positive sickle cell trait diagnosis, the notification letter that lets you know this is not disease, you'll live a normal life, nothing to worry about, and also very little to no follow-up. But what needs to be happening is the discussion in childhood. What happens to that letter? We have the junk drawer that letter may go into, and it's never spoken about again until if a child wants to become an athlete. So here are some questions. What is the parent's knowledge about trait? What is the child's knowledge about trait? What are other opportunities for screenings? And right now in the United States, there are no high school mandates. There are some high schools that do require testing, but there is no national mandate. And again, if more of these things are in place, then more prevention, we believe, would occur, and these young athletes do not pass. We suggest 10 more conversations, or a total of 10 or more conversations at the family planning, genetic counseling, at the point of diagnosis. Of course, as Dr. Smith-Whitley said, and I concur, more sensitive testing, in school testing and education. Transition is a big subject in the sickle cell disease arena, transitioning from pediatric to adult care. Sickle cell trait is a part of that transition conversation as well. Dating and sex education in school. Yes, NCAA sports is a good place for it to be as well. And we also, something happens here in the United States every October, which is Breast Cancer Awareness Month. The world turns pink. You have pink footballs and pink cleats and billboards and fire trucks. Everything is pink. That is an example of universal education. Everyone's not going to get breast cancer, but everyone's being educated about it. And my personal feeling is the same should be happening with sickle cell trait, especially when you think about the numbers, the 4 million, the 300 million worldwide. And then recruit what we are calling sickle cell allies, those people that may not be physically affected, but are educated and aware enough to care and to manifest that care in tangible ways, such as funding and sharing and so on. Dr. Smith-Whitley covered these numbers. This is why sickle cell trait matters, because this is something that affects more than just the presumed African-American, people of African, Caribbean, Asian, Indian, Italian, Irish, Mediterranean, Greek, and Turkish descent. So virtually anyone could have sickle cell trait. It is not a skin color thing. This is a bloodline thing. This is why it's important. And any one of us, or if it's not us, we know someone. 1 in 8, 1 in 13, depending on the numbers. So we have tried to just whittle this down to something more easily palatable. What can be done? Well, here is what we have, the research is showing risk factors. Major risk factors for the exertional sickling is dehydration, elevation, exertion, and then there are some other conditions such as the RMC that was mentioned. Here's a picture just to give you a visual. This is a picture that I actually took, that top left corner, of young people playing on a field down in Florida, but I also observed that there was no water in sight. But we also see our plants being watered. We also see water being provided for our pets, and even water being put into our cars. Why do we do that? We do that to avoid our plants from dying, our pets from becoming lethargic, our cars from running hot. Well, in order for a human to avoid dehydration, it is advised that we consume half our body weight in ounces of water per day. And in pre-COVID, when I'm in a physical presence of people, I always ask how many people, based on the standard of consuming half your body weight in ounces of water per day, are dehydrated. And unfortunately, most of the hands go up in whatever arena that is, because this is something that is just not widely practiced, but it's a major difference maker. Now, add this to a blood disorder that requires hydration for optimal health, then we start to enter the danger zone. Protective factors for sickle cell trait exertion to prevent that is gradual intensity. What happened to Devon and others of these athletes, usually it was the first day of conditioning. Usually it happens within the first hour. And it's usually happening when that young athlete has gone from rest to intensity too quickly. And the recommendation is that there is a gradual increase to intensity. Work your way up to intensity. You are also to be hydrating before, during, and after physical activity. And you're also to be allowed recovery breaks, which is also something that Devon was not allowed. And it was the difference between his identical twin brother living and not dying, because he was able to access some semblance of recovery as well as hydration. Simply put, warm up, drink up, rest up. This is our message. This is our message to parents. This is our message to the young people. This is our message to coaches, to trainers, school nurses. Very simple. Allow these young people to warm up. Allow them hydration before, during, and after. Do not associate working hard and hard work and weakness with drinking, with hydration, and allow them to recover. There are other adverse health associations, splenic infarction that have been mentioned, RMC, even avascular necrosis, acute chest syndrome, and as we're all experiencing, COVID-19. And we have identified quite a few opportunities, things that need to be done, what we see needed. And here are, again, some barriers to the sickle cell trait literacy. And I'd like to point this out, especially when I interact with patients, with trait patients, parents who have children who are in pain, not being believed, just curious about why is my child has a sickle cell trait. This is not full-blown disease. Well, in defense of a lot of the providers, medical school curriculums, the typical medical school curriculum here in the United States, 5 minutes is spent on sickle cell trait in a typical medical school curriculum. So many providers are not armed with the education that they need about sickle cell trait. And often our trait warriors find themselves educating their doctors about their condition. Of course, there's stigma, association with weakness. Guilt and minimization. We find this in families. You have a family with children, maybe there's a child with disease and then other children that have trait. Trait children may not speak up about things that they're dealing with because of the major pain and what's associated with sickle cell disease. But we need to have a more open atmosphere for all of the children in that family, caregivers as well, because often if there's a debate, the child that is a disease warrior, their parent is likely a trait warrior. And then of course the rare designation, and this is specific to funding, research, awareness. We've got some hills to climb there with the rare designation, and I do know that that's going to come up again. But our opportunities, mandate testing for high schools and younger. better surveillance, research, funding, and therapies. There is definitely an association of funding with what's available via the pharmacies, the therapies, therapeutics for sickle cell. If that were available for sickle cell trait, and namely there is an opportunity, I feel, to address the oxidative stress that happens in athletes. If that could be prevented, then you don't have the ECAST. That's a general statement, but there is science that backs that. So I did a study on my own about sickle cell trait literacy amongst HBCU athletes, where we examined the knowledge and perceptions. This was a qualitative study where we did focus groups with parents, focus groups with athletes, coaches, and trainers, as well as the student athletes. And the bottom line of that study is that those young people, those athletes, desire education. They believe it's needed and not widely available. They believe that sickle cell trait education is something that should be experienced by all and not just student athletes. And they also, interestingly enough, expressed no threat of stigma. They said, I would want to know my teammate has sickle cell the same way I would want to know if my teammate had asthma. I may be able to help them on the field. And then, of course, they also advocate for the care and concern of the non-affected ally. And the ally is something that we have focused our attention on at the As One Foundation. We subscribe to the fact that all humans have a genotype, not necessarily a sickle cell genotype, but the AA is the genotype for no sickle cell, no copies of the sickle cell gene. So those are our ally warriors, we call them. If everyone understood that there is a connection that each and every one of us could have, we believe that recruitment of allies is easier and that pool is larger. And this is just a parent's guide that we have for parents to take to their coaches, to help them with these practices, something that they can show in document form. What can be done, what is advised, hydration is important. So we provide that via our website. And this is just a little bit about the work of the As One Foundation, how we do what we do. I'm thankful so much for this opportunity, looking forward to the questions.
Many thanks, Tomia. Thank you for your slide, for your conversation. I think it's very, very interesting for us, all the information. And I would like to make a way to Elizabeth Coroma, is a Director of Health Promotion and Education, European Sickle Cell Federation. Is here, Elizabeth?
Yes, I'm here.
Okay.
Sorry to interrupt.
Can you see me?
Yes, of course.
To interrupt, please. I'm sorry to interrupt. We just want to say if people have some questions, you can put some of them in the chat so we can follow up as well. Thank you.
Okay. Okay, Elizabeth.
Hello, everyone.
Hello.
Can you see me?
Yes.
Okay. My name is Augusta Elizabeth Cisse. I'm the CEO for Sickle Cell Intervention UK, and I'm also the director of the European Sickle Cell Federation for Education and also research in health promotion. Today, I'm going to talk about why is it important for Europe to implement a universal screening program and the need for follow-up counseling services and how ESCF is promoting that. I will share my screen if I can.
Just made you co-host now.
Okay. Let me look at that. Just having a technical problem here. Right. Okay. What I'm going to do, I'm going to read from my slides because I'm just having trouble, uploading this. Sickle cell traits affect approximately 300 million people globally. And about 1/3 of the European populations carry the gene, particularly the sickle cell trait. The European Medicine Agency stated that the sickle cell disease affected approximately 1.3 people in about 10,000 people in the European Union, which is equivalent to a total number of around 67,000 people. And also, why is it that we're having these problems in terms of the European sickle cell screening? I gathered that one of them is the globalization and migration. I read a book by Olivia Biolaje on human security and social inclusion. It clearly states that the wider history of human population movement and obviously over 2 millennia of socio-political and economic interaction between Africa and Europe. Well, the burden of sickle cell disease will continue to enlarge because of migration, as it is a vital that standardized data registration are done for better clinical outcome. People living with sickle cell disease travel across borders. And if data is a problem, how are all these issues going to be solved when there is no universal newborn screening across Europe? So that's one of my questions. So the universal newborn screening as ESCF, we have stipulated how is this going to be achieved. So one of them was implement pilot program based on feasibility studies and previous experiences. 2, evaluate costs and logistic challenges in choosing testing methods. 3, set up diagnostics facilities, promote new techniques. The fourth one is automatic logistics, public awareness campaign. So what are the resources that we needed in order to ascertain those figures? The resources we needed is physical resources like clinics, laboratories, equipment, reagents, mobile units, research, clinical trials, infrastructures, etc. Network of newborn screening across negotiated laboratory regions costs as a block with manufacturers. So all of those things need to be considered. Human resources, doctors, social workers, laboratory, technology list, genetic counseling, data managers, and so on. And the sources of support that we need is government health institution, charitable clinics, North, South, and South partnership with foreign universities and hospitals, other sources like private sector, the NGO, philanthropist, organization, etc. One of the objective of for the federation specified that the association shall be united with one voice of all and existing sickle cell patients, parents, organization in Europe to promote, to enable, to foster their needs through the provision, promotion, and strengthening of a strategic and collaboration alliance among all sickle cell patients across Europe. We've all heard about the topic that has been discussed today by the doctors about the sickle cell trait and the implication it's causing in terms of athletics, in terms of clinical care. So sickle cell disease is usually detected during pregnancy soon or after birth. In the UK, blood tests can also be carried out at any time of the condition to see if you're a sickle cell carrier or at risk of having a child with sickle cell with the condition. So the screening to check if the babies are at risk of being born with sickle cell disease is offered to all pregnant women in England. So in parts of England, where sickle cell disease is more common, pregnant women are offered a blood test, and they carry, if they carry the sickle cell, and also in areas where sickle cell disease is less common, a questionnaire about your family origins is used to out whether you should have a blood test for sickle cell. You can also ask to have the blood test even if your family origins do not suggest your baby will be at the high risk of sickle cell disease. Screening in the UK should ideally be carried out about 10 weeks with pregnancy, and so you and your partner have time to consider the options of further tests to find out if your baby will be born with sickle cell disease. One of the programs is the sickle cell screening program is vital. It is vital for women who screen positive for sickle cell or thalassemia in pregnancy to receive appropriate and timely consultation with trained genetic counseling and professionals. This helps and their family understands the results of and make decisions for pregnancy, with both parents and are identified as carriers for a hemoglobinopathy. Social, cultural, ethical issues arising from counseling individuals with sickle cell. So why is this important? And so why the competencies are so important? It is important that the family affected by sickle cell or thalassemia have access to appropriate genetic counseling to help them make personal, informed choices. I must stress that. The competencies contain important guidance, including handling sensitive information, access further information and resources, and how families can support and access ongoing support. In many cases, the practitioner will be a sickle cell trait counselor. However, these competencies are also relevant for other healthcare professionals, such as genetic counselor, specialist midwives, health visitors working in high prevalence area. People who inherited one sickle cell gene and one normally gene have sickle cell traits usually do have any of symptoms of sickle cell disease, but they can pass the traits on to their children. And mostly people have been advocates. I have been advocates about genotype, but we've had today as well that there are lots of medical conditions that affect sickle cell trait. And we also know that sickle cell trait is inherited from from both parents having passed on the gene. So 1 in 76 babies born in the UK carries the sickle cell trait. Approximately 15,000 people in the UK have the sickle cell disorder. Approximately 300 babies with sickle cell disease are born in the UK every year. So all newborn babies are part of the newborn bloodstream heel prick test. So when your baby is like 5 weeks, 5 days old, the key reason for offering newborn screening for sickle cell disease is because babies with sickle cell disease are vulnerable to serious infections. So by identifying babies early in their onset, they can be prescribed penicillin, and also specialist care they can be referred to. Newborn screening also detects babies who have traits. So these are all important for us to look at in terms of newborn screening. And one of the questions I've been asking myself I've been saying to myself that more research is needed to find out why so why some people with sickle cell trait have complications and others do not, because it's something that even ESCF can look at. So why do some people, because some people do have complications, some people don't have complications. So in a nutshell, we are talking in one voice as ESCF, in promoting sickle cell screening universally, because there are countries, it's only targeted countries. For example, in Europe, in Ireland, it's targeted, and migration, as I said before, that people are migrating from Africa, especially to come to Europe. So all of these things, we need data, we need surveillance, we need, in terms of public health perspective, we need surveillance, we need data in order to ascertain all this for a better clinical outcome. I do hope that you all have listened clearly on this subject, and for all of us to work together to raise our voice in one accord. Thank you so much.
Consi, did you leave? Thank you very much, Elizabeth. I'm not supposed to be hosting, but the president is quiet. Antonio? Geez, what's happened? Thank you very much, Elizabeth. That was really good. It's a good insight for the Federation. That is one of our major objectives, actually, constitutionally, is to maintain the campaign on the newborn screening, which has to be universal. So it has to be the same from country to country, no differences. So if a particular way is implemented, let's say in Ireland, it should be the same implementation in France. It should be the same implementation in Sweden, in Netherlands. So yeah, we look forward to working with you all and with the experts, Dr. Kim, on your research that you're working on, and Dr. Tomia Austin, and all the sickle cell trait, the carriers that are struggling, to learn more from you and on what we can do. So I don't know, it looks like Consi is missing, but Antonio will present the next speaker.
Yes, the next speaker is Farron Dozier, is from the US Army, retired, founder of WDC on Sickle Cell trait on USA. Welcome, Farron, when you want.
Thank you. If you could share the screen, I'd have a couple of slides. I know I got 10 minutes, so I'm going to just hit some key points.
Okay, perfect.
I will make you co-host, so you share yours. Yeah.
Thank you. And so I go to share screen. I'm going to go here. And we're going to play. All right. Well, good morning, good afternoon, depending on where you're located. I am Farron Dozier, retired Army Sergeant First Class, 24 years, medically retired, disabled veteran, and my new identity or my new conversation has become the sickle cell trait advocate. This is the presentation that I do when I go out to the military bases or the colleges or the high schools. So I'm going to cut through this rather quickly, but there's a couple of screens I want you to see. And I'm going to just give you the basic key points about my personal experience of having this inherited gene. I've been blessed to create an organization called What's the Count on Sickle Cell Trait Prevention. Started as a sports brand, but also now I use those initials to use for my sickle cell trait awareness organization called WDC on SCT. That's my daughter at the bottom. She also has sickle cell trait. One of my 3 daughters inherited that gene from me, which I got it from my dad, who I'm blessed to have had as a father, who passed away in 2019. This is just the brochure that I use to pass out when I go into the community. It gives you the basic facts. I call them the who, what, when, where, why, and how. Also information from the CDC toolkit. And so I acknowledge them for that, because that has been a great tool to be able to share with the community. And I just go through the basics when I do this with the military soldiers and in the high school and colleges, just the basics of what hemoglobin is, how the purpose of it does, as you heard, have a purpose to combat malaria. And of course, a lot of people think it's African Americans. We are #1, we own that. However, as you've heard, you can be, you have to go by your bloodline now. You just can't go by the skin color. So I tell people you have to know where your ancestors are from. It's very important because we're all mixed now. And then I give them a little bit of history, as you heard earlier, from 1910 all the way down to 111 years coming up this year. I'll also talk about how it's inherited if both parents have sickle cell trait, the 25% chance that the child can be born with the disease or normal, and then also the 50% chance that the child can be born with sickle cell trait as well. I'll also talk about the global aspect of it, 300 million people plus, and I give them the breakdown by each country of what that looks like. Very important. A lot of people are not aware. Then I give them a little bit of more breakdown of what it looks like with the red blood cells, normal, AA, AS, and then SS. And that those red blood cells with sickle cell only live about between 20 to 100 days, when your normal ones live about 120 days. So just give them some little basic insights on that. And then I tell them that, this inherited gene, just like your complexion, your hair texture, your facial features, we don't get to pick those as parents. We don't get to pick what our children eye colors that they get. So just like that inherited gene is passed. And with some people think it skips generations. It does not skip generations. With each pregnancy, those numbers start over. And so a lot of people have a lot of myths and stigmas about sickle cell trait. But this screen right here was where it gets personal. And this is what is written in the medical community right now, that most people with sickle cell trait do not have any symptoms of sickle cell disease. And as an advocate for the last 10 years, language is going to be very important for me and how we go forward. With that keyword right there, it says, although in rare cases. And so obviously it's been known to have risk factors. And I'm blessed to be able, one of those messengers to deliver these conversations now. I'm going to give you just my personal life around this sickle cell trait from past to present. At 2 years old, my mom said that I would wake up in the middle of the night with my arm aching, my left arm. She said I would be crying. And I remember age 5 because my grandmother would hold me over the sink and run warm water over my arm. That was the only thing that soothed that pain. 1975, they took me to the doctor. The doctor says, oh, he's 5, it's growing pains. Don't worry about it, he's growing. Well, I'm about to be 51 and that pain has not gone away in my left arm. And in some cases, it's worse. And 1989, I joined the military. I do my physical. Nothing was shown to have sickle cell trait. 1999, I'm transferring to Michigan to become a supply sergeant for an infantry company. So I did my second physical at the LA Air Force Base. They test their soldiers and their airmen for the sickle cell trait. So they found my sickle cell trait at age 29. And they called me in a panic, like, you need to come back to the clinic like today. And so I rushed back to the clinic and I'm like, okay, do I have something? And the doctor says, do you know you have sickle cell trait? I says, no. He said, okay, we just want to let you know that you're a trait carrier. And I'm like, okay, well, I have a cousin that has sickle cell disease. He's like, no, it's not sickle cell disease. You're just a carrier. There's nothing to worry about. He talked about having children. I'm like, I'm done having kids. So, that's a little bit late. And so I'm transferring out of state. So my mind is thinking on, moving to another state. That's at age 29. Now, mind you, at age 28, my last daughter was born. And I got a letter from the hospital that she was a sickle cell trait carrier. But I got the letter, I looked at it, we looked at it, and I put it in the drawer. So I understand that conversation, how it gets missed. So in 98, I found out she had the trait, still didn't connect it to myself when I found out the next year in 99, and I go about my life. But I've always had these kind of health problems, my arm aching continued, nosebleeds, just different things that, just part of life, I thought. Okay, let's stop sharing. Can't get it off. So in 04, 05, I was deployed and we were training our American soldiers and Iraqi soldiers together. And I had a lot of health problems during that year of training. I could barely walk sometimes. My hand was inflamed, just having just different health issues. And they said it was tendonitis in my arm and just things like that, gave me Motrin. In 06, I'm done with that deployment. In 05, 06, I go to my military school. I'm a sergeant first class at the time. So I'm at the E8 Academy called the Master Sergeant Academy up in Central California. My 17th year, I got up to do that normal exercise test. So I got out, did the push-ups, sit-ups, and I was out doing the 2-mile run. And we're trained to sprint that last lap in the military. So I heard the instructor, 15:45, 15:46. And I'm like, oh, I'm doing pretty good. So of course, my brain kicks in, take off. And I remember when I look back that when I took off to sprint, I felt this electrical charge come over my body, but I didn't think nothing of it. I was just like, okay, you know, whatever. And across the finish line, 16 minutes, put my hands over my head to get air in my lungs, all the things we're trained to do. But all of a sudden my peripheral got dark and I started feeling weird. And so I kneeled down on the ground, I lay back, closed my eyes, because when I opened my eyes, everything was spinning like 1,000,000 miles an hour and I was nauseous. Medics came and got me, rushed me to the hospital. I'm in the bed, doctor gives me an IV. He comes back in and says, you ever had kidney problems? I says, no. He says, well, you do now. And then he walks out. And I'm laying there with my instructor like, what is going on? He comes back and says, you know what? Freak accident. You're probably dehydrated, heat stroke. I'm gonna give you another IV. Take the rest of the day off. You should be fine. Military approved me to have that day off. I wake up and I'm worse. Everything is still spinning. I'm throwing up. Nothing will stay down. I go back to sleep. They come back in the barracks after class and they rush me back to the hospital because my state is getting worse. The night doctor did some more tests and he saw that my creatinine kinase levels, my CK levels were at 12,000 and they were rising. Well, those levels at age 36 were supposed to be about 150 and they were at 12,000. So when he did his initial blood work and checkups, there is a condition called, as you heard, rhabdomyolysis. And so I was experiencing rhabdo at that exertion point. And still nothing was connected to sickle cell trait, just the rhabdo diagnosis I was living with now, severe muscle, skeletal damage, joint damage. I have double vision, like I have secondary health issues, ended up with arthritis from these exertion. And so that was 2006. 2009, I've been going to the doctor for almost 2.5 years. And my doctor realized that, you know what, Farron, you just can't run anymore. And so because when I got on the treadmill to exercise, I got off the treadmill, I feel like I was on a roller coaster ride, like I was still just kind of out of it and groggy. My CK levels did go down to about 500. So we were, pleased with that, but I just could not run. So I figured I'd be fine. I'm in the military. There's other events that I could do, the walk, the bicycle. So we turned that paperwork in to get cleared. And when they look at the diagnosis, the military was like, oh no, you can't, in fact, you can't exercise anymore. You can't carry a weapon. You can't do anything until we determine what happened to you. I'm like, that's like almost 3 years ago. I just can't run. I can do another event. They said no. So they started the medical board process, which also, I made that mean my life was over. So when we talk about mental health, our physical and our mental go together. And so now I'm dealing with my mental health and I'm depressed and I'm spiraling out because I'm worried about my career. And I'm at my mental health appointment and the officer that was my platoon leader during the war of 04-05, we ran the platoon together. I passed him on the base 5 years later. And he's like, how you been? I'm like, you don't want to know. He's like, tell me. I'm like, man, my muscles, I could barely walk, my mental. And he's like, you know what? Something like that happened to me where my muscles locked up, but I have sickle cell trait. So I have to drink extra water, take these vitamins. Now this is 2010. I'm like, why does that sound familiar? And then I remember my exam from 1999. And I go back in the clinic and I say, can you print off my document from my physical in 99? Sure enough, they printed it off. I read it, positive sickle cell trait, AS. I took that to UCLA because I was seeing a rheumatologist because I was diagnosed with arthritis. I gave that to her and she retested my blood again, of course, positive sickle cell trait test. And she also could determine that about 40% of my red blood cells was the S gene. And so when we did that research, we found that athletes, military, all these conversations and risk factors that I had no idea about until I was 40 years old that could be triggered to sickle cell trait. By providing that information to the military, that just reinforced my medical retirement. And it took them about 2.5, almost 3 years before all the initial paperwork was processed and I was medical retired at 24 years of service. In the midst of my depression and anxiety and worrying about what my life was going to look like, I was blessed to meet a mental health provider who asked me, "What are you going to do when you retire?" I says, "Well, I have an idea of sports brand to sell some t-shirts." So he's like, "Let me show you something." And he opened up a college book for student athletes, and it had paragraphs about sickle cell trait, exertion, and rhabdo in college athletes. And I'm like, "You know what happened to me?" He's like, "Yeah, it happens a lot. It gets misdiagnosed or people just don't know." He says, "So what you could do is you could become an advocate." I'm like, what's an advocate? He's like, "You can actually use your sports brand, sell those items, raise money, and you can travel and speak and educate people about what happened to you." And I was like, "You gotta be kidding me." And so instead of worrying about my life at 3 or 4 o'clock in the morning where I couldn't sleep and wanted to commit suicide because I thought my life was over, I found this community of people that I didn't even know existed, and I became an advocate. And here I am in front of you today, being able to share how important these risk factors are. I still get emotional because meeting Dr. Austin, when you're out here trying to give people this information, and then you meet a person like Dr. Austin who has done research, she's like my saving grace because she has been able to find other people and find this information. So as me as an advocate, I will use my voice to share this information. It is very important. One of my board members is on the line, Dr. Maisha, who also is going to share her information. It is very important for us to really understand the risk factors. My daughter now advocates with me as well. I've been able to travel across the country to Germany, to military bases, to high schools, to elementary schools. This conversation is very, very important. And I want to say to our community, if you believe you're born for a reason, then your voice is necessary. For me, sickle cell trait has its own awareness, education, and prevention conversation, but it does meet with sickle cell because when those two parents have those inherited genes. So yes, we need to focus on sickle cell trait by itself, but also includes sickle cell disease community as well. So I broke mine out for three areas: awareness, education, and prevention. Awareness is these kind of conversations here. The education is doing presentations, but also I have a college board education. I'm getting worked out to get in more areas. And then the prevention is the testing, as you've heard. For me, the newborn screening is perfect. However, it's a little bit after the fact. So if we can have conversations before families start to decide to have children, that could minimize some of the mental health, the regret, the resentment, the stuff that comes with that, not knowing. Because if you ask people in our community who found out after the fact, they do have to deal with a lot of their own mental and what the decisions that they made. So if we can have these conversations ahead of time and inform couples and parents, then they will have a choice. They'll have a choice and they'll have the information and the resource. So if that child is born with the disease, they're prepared, they're not surprised. And so again, that's pretty much, what I want to share. All my platforms are at Farron Dozier. If you want to look for me, I'm always open to speak. I live for this. This keeps me alive. This is something that I've been able to give my life work to. So I'm appreciative. Thank you.
Wow, I'm gonna cut Concy off and say something here. That was very, very, I don't know what to say. It's you almost brought a tear to my eyes, Farron, and I'm glad that advocating for sickle cell trait helped to take you out of the depression and them struggling with mental health. And it's really important for people to understand that there is a lot of things that go on when you're struggling with something that you just find out at a later stage and you're struggling with it, but you don't know who to talk to. But I'm glad that you found somebody, you found your mission and vision, and now you're working towards educating others. So thank you very much for joining us and for presenting such a story and experience. I'm sorry, ESCF members, if I felt I needed to say something there, Konsi. So thank you very much. Thank you.
Thank you.
Yes, sorry I couldn't give any presentation to you, Farron, later on, earlier on, because I had a cough and I didn't want, to sound as if I was dying back here, but I'm better now. So I would like for us to hear from Dr. Maisha, if you have a few words for us. Thank you.
Yes, thank you so much for the introduction. I'm Dr. Maisha Pasante. I'm a family medicine physician. I am on the board of What's the Count and recently launching Inscription. We do, among other things, sickle cell trait advocacy work. Being in primary care medicine, I am on the front line. I am catching all of these patients that we are talking about that no one wants to take care of. I am catching misdiagnosed or improperly diagnosed conditions when the S trait is combined with the C trait and that's been missed. I'm taking care of patients who are suffering and cannot get adequate help and support. One of the most important messages that I wanted to bring to the conversation today relates to the interaction between sickle cell hemoglobinopathies and when we classify sickle cell trait as a disease. And what do we mean when we say, as not a disease, when we say something is benign, versus when we define something as a disease. So the definition of a disease is a disorder in structure or function that has specific signs or symptoms. So to me, the source problem here is that we do not classify sickle cell trait as a disease. If you don't classify it as a disease, then you can't say that you need a treatment. It's benign, nothing to worry about, as Dr. Tamia said so eloquently, as Farron explained in the story that what he actually experienced. It was nothing to worry about until he almost died from it, until all these athletes are dying from it. The athlete deaths are so significant in this realm because we can't blame it on anything else. So because sickle cell trait has been classified as not a disease, as a benign carrier state, when it does show its head and cause problems, we're not connecting the dots. So we're not doing further investigation. As Dr. Smith-Whitley pointed out, we're not looking for those other hemoglobinopathies that can combine, like the beta thal, like the C trait, the E trait, and then make it the same as homozygosity. Also, there are S-Antilles, S-on-man, where you have AS on your hemoglobin electrophoresis, but that S makes you just as sick as the homozygous state. So rather than saying it's not a disease, a better classification is to say that it is a spectrum, that we must treat the patient, not the numbers, because we'll never be able to find all the different genetic factors that can contribute to a particular patient experience, what Farron experienced, what several of my patients are experiencing. And it's sad because it's often difficult to get a hematologist to help you. I'm so thankful to hear the presentation that Dr. Smith-Whitley made, because that's a hematologist who's willing to accept and understand that sickle cell trait may behave like a disease. And so that's the major message that I want to bring is we need to change the conversation and engage in re-education, and then begin to treat these patients who are suffering with nowhere to go. Quick case story on that first point of the combination of S and C or S and thal. I had a patient at 58 years old who came to me, deaf, severe pain, bilateral avascular necrosis. And I think mostly everyone here knows what that means. He was diagnosed as hemoglobin AS sickle cell trait. He was not being cared for by a hematologist. He didn't know he's supposed to hydrate. His favorite drink every day was a 32 ounces of Kool-Aid. Upon further investigation, he had SC. And I had to make that diagnosis. 58 years old, suffering with SC, which presents just as badly as SS would in any case. I have another patient. This is another part of my message has to do with beta thal and alpha thal. On your hemoglobin electrophoresis, these may present as A2. It can be normal or high normal. And in that case, we need to realize this patient may be S thal, not just AS, but no one's checking for it. And again, they'll be like my SC patient. I have another patient with alpha thalassemia. She's alpha trait only, I believe, but I'm having the hardest time getting her diagnosed. Her A2 is low. Why? Because she doesn't have enough alpha chain. So she's mostly beta chain. So again, she's actually suffering the same symptoms as someone with sickle cell trait who is symptomatic. So with sickle cell trait, you can have crisis. How is that benign? With sickle cell trait, you can lose an organ. How is that benign? With sickle cell trait, you can have symptoms where you're not quite losing an organ, like a pro athlete who's healthy, but you're not a pro athlete, but you're sick all the time. You're fatigued. You have these weird pains, like Farron said, growing pains at 40. How is that? You can't quite get up and go to work. Or my patient not my patient, a woman I met at an insurance company working who had pulmonary embolism, legs were swollen, lots of pain. Her D-dimer remains elevated. She's scared out of her mind. She can't get treatment. She can't get care. So the next part of the message is we need to develop protocols for sickle cell trait as we are developing protocols for sickle cell disease. It is a disease. It is part of the spectrum of disorders in sickle cell. We need to have hydration. They can go to the hospital. They can get fluids. They can get morphine. They can get oxygen so that the process stops and they don't go to the point of death. These athlete deaths that we've talked about were preventable. We could have done something. We didn't, because we say, oh, epidemiologically, sickle cell trait doesn't decrease your lifespan. Yes, but then we said, oh, when this person had this problem, that wasn't because of trait. That was just because they had the problem for some other reason. There's kind of a psychosis going on, and we need to change that story so that these patients can get care. So number one, they need to get proper diagnosis. That's the first part of changing the conversation. Number two, we need to listen to the patient and treat the patient that is in front of us. What are they presenting with? We have a saying in medicine, and Dr. Smith-Whitley knows this. We all heard this in med school. If it walks like a duck and it quacks like a duck, it's a duck. So how come a person is presenting with the exact same picture that someone who's homozygous will present with symptomatically, but because their hemoglobin, H and H, is normal, their LDH doesn't go up, we say, oh, no, this isn't sickle cell. You're having the same picture, but this isn't sickle cell. But then we know someone with SS may not have a change in their hemoglobin and hematocrit, may not have a change in their LDH, but they are in crisis. Treat the patient, not the disease. This is re-education of the clinicians. Re-education of the patients goes under this bullet point number 2 of changing the conversation. The patient needs to know, like Dr. Tamia said, I want her to say it. I love when she says it. Say it for me really fast.
Warm up, drink up, rest up.
Yes, I love it. Every time she says it, I love it because that saves lives. The patient needs to know that. And then it is not just who you marry, AS, and oh, you might have a child. You could be sick with trait. You could be sick. You could have a child that presents like SS with a person who doesn't have AS. They can have C trait, E trait, D trait, thal. All of those conversations need to change. I can't tell you, like Farron, I'm ready to cry. This is a conversation. This is a fight we've been having. I've been having it for close to 20 years now. Farron and I together have been having it for 6 or 7 years with the What's the Count Foundation. He is my inspiration. As a medical doctor, going against the grain can be very scary. As a primary care physician, you're often told, oh, who are you to speak about this area that a specialist handles? But We see it at the primary care level. We can't get, right now, if you try to treat, you want to give narcotics, oh, they're a drug seeker. But the AAFP did an article. Less than 3% of patients who are diagnosed with sickle cell SS are drug seekers. That's less than the general population. The health belief model of this particular ethnic population is they don't want to go to the hospital. They don't want to seek care. So by the time someone with trait is seeking care, they're very sick. Their life has been impacted adversely. We are stronger together. There's a 300,000 with SS. There are 3 million to 5 million of us with some form of sickle hemoglobinopathy. Medical dollars are allocated often based on the numbers of people affected. That's why we always say, oh, sickle cell is the #1 genetic disorder, because that gets us more healthcare dollars. So instead of us saying, oh, if we try to say that all these people with trait could have a disease, now we're going to have less resources. No, we'll have more resources. And we are stronger together. We need to unify and talk about the spectrum, re-educate the physicians, come together. Yes, we need more research, but actually there's already tons of research. Dr. Smith-Whitley made an extremely good point. Most of that research is retrospective. We need prospective studies that show, hey, the recent military study that came out said, oh, they don't have long-term complications. How can you say that when we didn't follow the people out?
Dr. Maisha, we are running out of time.
I am done. That is my main message, that we need to change the conversation.
It's amazing. It's amazing. sorry, but we will talk again. Thank you so much for that. Thank you. So I will help the hosts to introduce Ms. Palmira de Andrade to share her experience, please. 10 minutes, and then we go to a discussion because a lot of people have questions. Thank you.
Palmira, do you mute that? Yeah.
Kan ni höra mig?
Yeah, she's actually going to speak in Swedish. I'll do my best to translate as much as I can.
I choose to speak in Swedish for 2 reasons. For the first, I had my God, it's disappear here. I had a severe stroke, and after that I lose some words and I lose some of my English, but also because we have a group of parents in our association in Sweden that don't speak English at all. Our group have a lot of almost are Africans for different place, and they don't speak English. And I hope that they are looking, and I would like to speak in Swedish so they can understand also. Thank you. Ja, jag heter Palmira Rosado, är 49 år, kommer från Angola som ligger i Sydvästafrika.
Sorry, I need to translate that fast. My name is she's saying, my name is Palmira. She's 49 years old and she's from Angola.
Ja, jag kom till Sverige när jag var 13.
She came to Sweden when she was 13 years old.
Jag fick veta att jag hade sickle cell, eller att jag var bärare av sickle cell-anemi när jag var 8 år i Angola.
Yeah, she found out in Angola when she was 8 years old that she was a carrier of sickle cell trait.
För att jag hade ganska mycket smärtor och på grund överallt i kroppen hela tiden, och på grund av att det fanns den sjukdomen i min pappas familj, då ville min mamma veta om det handlade om det. Men det visade sig att jag var bärare.
She had a lot of pain in her body when she was younger, and then her mom wanted to find out whether she was a carrier or she had the disease, and they had in her father's side of the family, they had the disease. So.
Och då fick man reda på att jag alltså vara bärare. Men i Angola så såg de redan då att bärarskap innebär att man faktiskt kan bli sjuk.
Yeah, so in Angola, they did already tell her that if you are a carrier, you can also get sick. That she already knew from the beginning. So.
Men det fanns ingenting att göra åt det. Man fick ingen medicinering, ingen hjälp och ingen som sagt struktur om hur man skulle göra för att inte bli dålig eller för att ta hand om sin hälsa. Utan det var bara att få veta och tack och adjö.
Yeah, so there were no medication, so the only no treatment or anything. So the only thing you had to do was just try to live on and move on. That was the only thing they had. So.
Ja. Sen kom jag till Sverige. Då är jag 13 år. Och jag spelar basket och vill bli bättre. Och då får jag som jag tror en stor kris här. Och läkarna tror att jag bara hade kanske någon sjukdom från Afrika. De där tropikalisk sjukdom. Som malaria eller någonting sånt.
Then when she was 13, she moved to Sweden and she played a lot of basket and she wanted to become better at it. But then she had some kind of crisis, and the doctors here in Sweden, they thought that she had an African disease or a tropical disease. So that's
malaria eller something like
malaria or something similar to malaria. Yeah.
När jag är 17 år, och jag har alltid som Farron haft smärtor överallt, och de har ju alltid sagt men det är för att man växer. Precis samma sak.
Okay. As she's comparing to Farron, when she was 17, they said that she had growing pains or something similar to that, but she's just growing. There's nothing to be taken serious. So.
Då återvänder jag till Angola, och när jag är 18 går jag i armén i Angola för att bli militär.
So then she returned back to Angola and went to the military to become military person. So.
Ja, och där fick jag faktiskt, jag gick in i flygarmén då, och vi fick lov att plugga i Portugal.
So there she worked with the flying military, and then she moved. They went to work in Portugal
to study military. Yeah. Och då fick jag en jättekris, för det var ju väldigt höga tränings, precis som Farron.
Yeah, so in Portugal she got into a crisis because of hard training, as you said earlier, Farron. So.
Och de bestämmer sig, eller tror att jag har fått blindtarm och ska operera mig akut.
Then they said that she had like appendix problem. They were going to operate out her appendix. So.
Och de gjorde det, men jag hade ingenting.
She didn't have any appendix, so.
De bestämde att ta bort den ändå,
so
fast det var inget fel med den.
They took it away even though there were nothing wrong with it. So.
För de kunde inte förklara varför jag hade så ont.
They couldn't explain why she had that much pain, that crucial pain.
Men jag fick då inte fortsätta i militären, för jag blev, precis som Farron, väldigt dålig. Mina värden blev bara värre och värre. Och då fick jag komma tillbaka till Sverige, där min pappa bodde.
So they didn't, she was not allowed to keep on studying to become a military person, because she were in pain most of the time. So she moved back to Sweden, where her dad was living at that time.
Och där började det. För här i Sverige.
So everything started in Sweden then, because there's a lot of,
Då började jag få kriser ganska ofta. Och de trodde allt möjligt av de där kriserna. Men inte sickle cell.
So she had a lot of crises during that period of time, but nobody believed that nobody couldn't explain, or nobody knew that what that was. So.
Sen berättade jag själv 2005 när jag fick diskbråck. Men jag har sickle cell-anemi. Eller jag är bärare. Och då var det, läkarna var ju allihopa väldigt snabba att tala om, det är ingen sjukdom. Du glömmer det här.
2005 she had back pains, and she was trying to explain to the doctors that she was a carrier of sickle cell, but the doctors kind of brushed her off and said she doesn't have a problem, she's only a carrier, so there's nothing really.
Det är ingen sjukdom. Och
It's
i
not a
Sverige
disease.
det är ingen sjukdom.
And in Sweden we don't see it as a disease if you have the traits, so you are not you don't have any problem. So.
2009 får jag alla mina organer som börjar stängas av. Den största krisen jag har haft faktiskt. De trodde 99% att jag hade cancer, lymfomcancer, var det de sa. Jag var inlagd i 3 månader.
So 2009, her organs, inner parts were shutting down, and almost 99% of her body was shutting down, and they thought that she had lymphoma, cancer. So
they say that I had it.
Yeah, they said that she had it. So she was in the hospital for 3 months.
De gjorde alla tester, det var inte cancer. Då började de söka, i och med att jag var så dåligt, jag var så svullen, jag var ingenting, jag låg på intensiv, så såg de då att jag hade lupus.
Oi. So during that time in the hospital, she was swollen. They took all the tests, but they couldn't find anything. Then they said that she had lupus.
Och då började de utreda för det.
So they started to see what she had during that time.
Men de kunde inte hitta att det var lupus.
They couldn't find that it was lupus. So.
De kopplade in en hematolog och de behandlade mig som en sickelcellpatient, men de erkände inte att jag hade en sickelcellkris.
So what they did, that they contacted a hematologist, and they couldn't admit, or just admit that she had sickle cell trait, but they were treating her as a sickle cell patient at this time then. Yeah.
Och det tog mig 4 månader innan jag kunde få gå hem. Och sen dess har jag har hunnit få 2 strokes, hög blodtryck.
So she was in the hospital in total for 4 months, and after 4 months she went back home, and during this time she had two stroke. Vad var det mer?
Ja. Väldigt hög, börjar lida av högt blodtryck.
High blood pressure she got
och
as well.
Nedsatt njurfunktionen fick jag veta förra året.
And she got they told her that she has kidney failure last year. So.
Men ändå så vill ingen läkare koppla det till sickle cell, för jag har bara sickle cell. Jag är bara sickle cell-bärare.
Yeah. So even today, no doctor wants to connect that to sickle cell trait, because she's only a carrier. She doesn't have the disease. So.
Och de fortsätter att utreda mig på alla sjukdomar.
So what they're doing now, they're trying to find out what she has when it comes to every disease, but not sickle cell trait.
För jag är bara bärare.
She's only a carrier.
Det är så långt man har kommit i Sverige.
So this is that far we are in Sweden today.
Och det här vill jag dela med er.
And this she wanted to share with all of you. Är du klar?
Ja.
Yeah.
Thank you
So-
very much.
Thank you. Wow, thank you very much. It's like we are learning more and more and more. This is amazing. I keep taking over. I'm sorry. There you go.
Yeah, and now I'm getting annoyed. Now I'm not going to pay any fines. So, no, the thing is, I'm really happy that Palmyra decided to go on today and discuss it or share this with all of you, because that's why in the beginning I said this is a topic that is so important. We need to address this in order to move forward, in order to find ways or just educate people. As Tomia said earlier, in October, we have the Breast Cancer Day. Sickle cell should be the same, because it's so important, not just having the disease, even a carrier. It's for me, I can cry out loud, or just I get so annoyed because it's so important. We need to deal with it, and it should have been dealt with, as I said earlier, long ago. And we are here now, but I know that together we can do something good out of the outcome. Is going to be good. So, Laura, you're welcome.
Thank you. Thank you very much. And to that effect, I will just ask a very lovely lady, Miss Tessa Youngner from the SCD Coalition in the USA, to say something. Thank you very much.
Thank you, Laura Ruth, and thank you all so much. This has been an incredible morning with all of the wonderful speakers from various perspectives, both from the medical, the social, and the lived experience, and advocates. It's just really heartwarming to be here and really appreciative of your time. As Laura Ruth said, my name is Tessa Youngner, and I am a sickle cell disease program specialist with the American Society of Hematology. So we're based in Washington, D.C. in the United States, and we are our largest hematology or professional society dedicated to conquering blood disorders in the world. And so we do work in the United States, but also globally to help improve the lives of those living with sickle cell disease. A large part of my role is helping manage the Sickle Cell Disease Coalition, which is an umbrella organization of over 90 partners from a variety of stakeholders. We've got federal partners, industry, providers, and public health organizations. We've got patient advocates, researchers, et cetera. We're very grateful to have the European Sickle Cell Federation as one of our members, as many of the other partners on this call. And we definitely realize that trade is a huge issue, as was kind of been highlighted today. And we will be launching a task force, actually, that is going to be dedicated to advancing research and advocacy around screening, and just promoting the documentation and awareness of sickle cell traits so we can move the ball forward for the community. So many of you will be hearing from me soon, because I think that this is a great opportunity for us to be partners. But I just want to plug that in there, that we are launching this force and are taking dedicated steps to moving the ball forward on this. And I'm really excited for this Q&A session to hear some of your great ideas and learn from each other and kind of help us get a path forward as we kick off this task force. So thank you all again, and thanks so much for being here.
Thank you. You're welcome. So we are going to start the question and answer session, and I'm going to ask Ms. Jenny Kalea. She's content manager for ESCF. She's the one working on building our beautiful website, and she's also runs her own company, My Friend Jen. So she will talk about a bit. She will give us the questions. Maybe we leave her to for now. So give us the questions. So yeah, go ahead. Thank you.
Thank you, Laura. Hi, everyone. Janika Leah. I thought it would be best I'd just go through the questions, because I know that we're kind of running over time. And then the relevant people, whoever wants to take the floor to answer the question, would be good. So the first question that we have here. Good afternoon, all. Thank you so much to Dr. Austin. I have sickle cell trait and have had many severe complications since the age of 5 years old, and I'm now 36. I'm of Zambian and Moroccan heritage, and I'm awaiting further genetic testing to find out my hemoglobin type. Is it normal to present under normal circumstances and not just the special circumstances most publications state? So I think that's probably, is it usual to still present complications under normal circumstances and not just those that are in perhaps athletics, sports, military and things like that? I don't know.
I think we'll let Dr. Kim answer that.
Yes, I think that that's a very important point. And one of the things that I try to to give you a perspective on is that individuals with sickle cell trait can have differences every day that they may not even realize. So when your kidneys do not concentrate very well, the medical terminology for that is hypostenuria. And that can cause you to have to wake up multiple times in the middle of the night to go to the bathroom because you produce more urine. Those subtle differences can also be seen with blood in your urine. Certain circumstances, if you have a cold, if you have certain medications, if you could become very dehydrated, you can have blood in your urine. And in worst case scenarios, blood in your urine can be a sign of renal medullary carcinoma, that aggressive tumor. So these are things that I think are very important for individuals with sickle cell trait to understand, that even not under severe, strenuous physical exertion, you can still have manifestations or associations with sickle cell trait.
And as far as my daughter, my daughter's story, now I wish, she was here to share this for herself, but when I went to Michigan, when I found out in 99 and I went to Michigan, she was 2 and she would cry, my hands, my feet. And I wasn't doing this work. So I was like, oh, growing pains, don't worry about it. But she will tell you if she's stressed out, if the weather is conditioned is cold, her hands, her feet and her shins is where her pain is. And she was 2. And so that's why, she's advocating with me, because she has her own experiences about having the trait that we had no idea that these were symptoms.
Right. So that just goes to show that, it's important for everyone to know and be awareness. Sorry, Laura, was I meant to introduce myself or am I good to just carry on? You're muted. Are you? Yeah.
Because of time, we just move on.
I'm just trying to go. It's fine.
Yeah.
Okay. So another question we have. Question 1: is the 300 million living with trait actually confirmed, or could this be a larger amount? And there's a 2-part question. Question 2, what is the prevalence rate in India, if anyone knows, since they are now number 2 in the world for prevalence behind Nigeria? If anybody knows.
To answer that.
Well, I mean, when you look at 300 million, even those numbers of sickle cell, they're from the 70s, 80s, and they've been these numbers for years. So we believe that those numbers are higher for sure. We believe that.
Okay.
Yes.
And does anyone know the prevalence rate for India?
No, I'm sure we can Google that, but I think the point of the question has to do with, are we really sure about those numbers? And I think one of the resounding, repetitive points we made today has to do with the fact that many people are undiagnosed, misdiagnosed, don't know their diagnosis. So we are not adequately newborn screening, where people are finding out in adulthood, as Farron expressed. So I think the short answer is those numbers must be higher.
The number that I have on my presentation for India is right now is 20 million. That was the last numbers. I have Nigeria at 30 million and India's at 20, Congo's at 16 million, Brazil's at 9 million, Tanzania's at 6 million, Kenya's at 5, Ghana's at 4 million, Saudi Arabia's at 4 million, and the USA is between 3 to 4 million.
And it should also be noted that there is still very much so resistance in the Caucasian population, whether or not it's the provider that believes that these people that present as white or Caucasian can be positive, or even themselves, the purity of the blood, all of those things that come into play as well. So surveillance is key, and really good surveillance, of course, is the best.
Yeah.
Fantastic. Laura, there's a number of questions wondering if this recording will be shared.
Yes, well, we have to find out, because of GDPR purposes, we will contact the speakers to get consent, and then we can share the recording.
Okay, and just a number of praises to everyone that has spoken. and how powerful it is in giving people the confidence to speak out. Yeah, I think that is the majority.
So
We've got one here. I've been having problems bleeding since September last year and then stopped on the 2nd of January. I've begun bleeding again and it's now day 11 and I thought this was my menses. I believe it's related to my sickle cell trait status as I was clotting severely. My bloods came back normal and I was admitted with stroke-like symptoms in December after asking for brain scans since March due to severe headaches last year and being in severe crisis for 3 months in 2020. I'm exhausted, mentally drained, and now I feel this could all be related.
yeah, Dr. Kim.
Yes, I just encourage you to share information with your medical team about, one, the appropriate testing for sickle trait and other hemoglobinopathies. I just want to make sure that we know definitively what you do have. And then the second thing I would encourage is for them to understand that sickle cell trait is associated with complications. I believe Farron referred to that CDC toolkit, which we spent many years writing that. So I'm so glad that people are using it. I really encourage you. Good. I encourage you to get that. The other thing that is important is the National Academies of Science, Engineering, and Medicine report. That link that I put on my slide, you actually can go to a chapter in that and you can give that to your medical team so that they understand kind of what we know and what we don't know about sickle cell trait so that they will do the appropriate testing and evaluation on you. So I'm hoping those references give you the tools that you need to advocate for yourself for better medical care.
Thank you.
Do we have time for? Oh, sorry.
Just one more question. Can a carrier donate blood? Yes, you can. Well, you can in the UK. So yeah, I think I can answer that question. A hematology doctor said my medical history saw traits of thalassemia. In Sweden, we have very little or no information in regards to thalassemia. I'm also going blind at the moment, so writing is limited. How could you help?
So I encourage, again, thalassemia can come in many different forms, just like sickle cell. And I just want to say, Dr. Maisha, I think that your terminology is wonderful. I call them sickle cell syndromes. And so I really would encourage your team there's actually testing that they can do at the gene level to see about thalassemia. Also, when I hear about vision, I think about sickle cell. So I just want to make sure you get the appropriate testing because some of the things that you're suggesting we see in sickle cell.
Also, there was someone asked a question to wonder how many people actually in the chat, so there's 40 participants now, actually have sickle cell or sickle cell trait. So I think it might be easier if you have sickle cell disease or sickle cell anemia, full-blown sickle cell, if you could put a 1 in the chat, and if you have the trait, maybe put a 2 in the chat, and then we'll be able to, I'll tell you what the what the stats are after. Can we say it depends on a certain percentage of S gene that you will have health problems with sickle cell trait?
So I'm fascinated by this too, because I think that many of us, and as Dr. Maisha implied, you need to really pay attention to what the individual is saying to you are the problems. And there are things that vary the percentage of sickle within a cell for individuals with sickle cell trait and individuals with sickle cell disease. In individuals with sickle cell trait, the influence of alpha thalassemia is very pronounced. So you can actually have differences in percentages based on the number of alpha globin genes that you have. So it's very important that your medical team not only looks at the proteins, which are the hemoglobins and the chains that make up the hemoglobins, the alpha and the beta, but also the genes that control those. Sometimes they miss extra alphas, sometimes they miss differences in beta. So it's very important now we have very good testing down to the gene level, and they need to look at the genes.
And I know that some of the numbers, when you look up sickle cell trait percentages, they range from 25 to high 40s. And so there's a huge range. So you would have to be able to find out your specific numbers so you can determine that for yourself. So thank you.
So we're talking a lot about diagnosis, and that's extremely important, and we need to keep that conversation going. I hear a lot of suffering, and as a family medicine physician, the way we train in terms of the approach to the patient. I want to offer a couple of things to the participants who are deeply suffering right now. Number one, like Dr. Tamia said, you must hydrate. Remember, there was a question about what about normal conditions? Most of us walk around dehydrated every day, and this is a conversation I have, whatever your disease is. You should be drinking, for a normal person with no hemoglobinopathy, half your body weight in water every day in ounces. If you have sickle cell trait or any other sickle cell hemoglobinopathy, you need to be drinking more than that. And you'll begin to know what point you're doing well. I also recommend, and I have no stock in the company, I recommend something called Green Herb. Green is in the color, herb is in plants, by Green Vibrance. You take it according to the instructions, and now they have different flavors in case you don't like the taste. And especially for patients with trait, it can be a big difference. And I'd also like to recommend black seed oil, cold pressed, taken 1 to 3 times per day, can greatly decrease. I have a patient who went 10 months, homozygous, 10 months with no crisis, combining cold pressed black seed oil, honey daily, another herb called moringa, and changes in diet where he decreased starches and processed foods. 10 months with no crisis, homozygous. So imagine what that would do if you don't have as much sickle hemoglobin in terms of the heterozygous state. So Green Herb by Green Vibrance, black seed oil cold press, 1 to 3 teaspoons daily, lots of water, lots of vegetables. I just wanted to put that out there.
Thank you. I think that's really, I'm jumping in here, Laura, but I think that's really good because I've the stats have shown there's about 5, including myself, 6 people with full-blown sickle cell. There's 4 people with trait plus a parent of someone with trait and someone without trait. But I definitely manage my health and condition by, natural remedies, moringa. I'm currently in Jamaica, luckily, and I have a moringa tree in the garden. So I've been doing all these kind of stuff. But honestly, guys, there's so many natural things that you can look at to kind of help just to maintain. It's probably not going to cure anything, and it's not going to get rid of anything, but to help us maintain, hydrate, stay healthy, and things like that are so important. Someone's asked or left a really good question to say, what goal can we set today for a universal global newborn screening, or what goal could we set today for us to all kind of go forward and try and make a change?
With that question, I will ask an advocate, a great advocate with us here. Also, the organization is a member of ESCF, Ms. Elvi Ingoli, to say something about the newly implemented newborn screening program in Germany. So maybe that would guide us on how we can go ahead from here.
She here? Hello?
Yeah, sorry, Elvi, this is Elvi here, but we can't hear you.
Can't hear. Okay.
Elvie, we can't hear you. She's here. You see there. Sorry. Oh God. Yeah, it's not working. But as Elvie is going, I think we have Agatha. Agatha wanted to ask a question while Elvie sorts herself out. Agatha, are you there? She's currently on rest. So, do you want to try again, Elvie, before we close? It's not working. Okay. All right. Sorry.
I'm sorry. There's a question from KW to everyone.
Okay.
There. If Janika.
About the suggestions, is it the last one? Suggestions sound like what can be done in the Caribbean. Is that the question? I'll let you answer that question, Maisha, but the things that were mentioned, they should be accessible from like a normal health shop or someone. Can someone go on mute? Agatha, I think you're not muted.
Hello.
All the herbs and natural things that were suggested, you should be able to get them from, you know, health shops and
yes. Unfortunately, I don't like to plug Amazon because they've gobbled up so many mom and pops, but you can get all of it on Amazon if you can't find it anywhere else. That's why I was trying to be very specific about the brand and the name. You can even get moringa and moringa seeds. Moringa seeds, I want to caution you, they can drop your blood pressure. So you have to be careful. You can't have more than 2 moringa seeds in a day. The tea is safer. And you can get them anywhere in the world. You can get them shipped to you from anywhere in the world. Of course, it's easier if you're in the Caribbean or if you're in Senegal, where I go often, and having that moringa tree. Oh, I'm so jealous. I went and picked moringa off the tree and had it. It was amazing. So, you know, eating all of the like noni fruit in the Caribbean, if you can go out to your backyard and get the fruit off of the tree, you should be eating noni fruit every day. The noni fruit formulations that are currently available do not have a high enough concentration. When you're purchasing it, you need 200,000 milligrams per 2 ounces of noni daily to mitigate symptoms. And most of the formulations out now only give you 20,000 milligrams. It's not sufficient. But if you are in the Caribbean or you are in West Africa, for sure, I know you can get fruits there and in the Caribbean that will greatly help with your trait. It's a whole nother discussion about part of why we're so sick is because we are outside of the element which we were genetically adapted to have the foods. Like yucca root also can help with sickle cell, even though it's a starch. There's several roots and herbs that you can get in those places, but now you can have anything shipped all over the world.
Thank you. I think there should be another conversation, about
Thank you.
That's most of the questions. The rest are just kind of suggestions and things. So, and
Palmyra has a hand raised.
Go ahead.
So, do you want to ask your question, Palmyra?
Yes. Jag skulle vilja veta vad vi kan göra i Sverige för att kunna påverka i läkarna och ändra attityden vad gäller sickelcellbärare. Bara så enkelt som en information om att vi måste dricka mer. Inte ens det kommer upp.
She would like to find out what we can do here in Sweden in order to change the doctor's way of thinking around when it comes to the sickle cell trait, and not only the information, not even the information about drinking a lot of fluid, it's even up on the table yet here in Sweden.
Det finns ingenting. Här sägs det att vi är inte sjuka. Den kopplas, sickelcellbärarskap kopplas inte alls med andra komplikationer som kan dyka upp i ens hälsa. Hur kan man, och de tror sig veta bäst och mest, för det är de som är läkarna.
So she would like to because there's no information at all, and she would like to see what can we do in order to move on, because there's actually, they don't have the information, they don't know anything. So what can we as the people do in order to make more awareness when it comes to that?
I think for myself, like what Dr. Maisha has mentioned, like I tried to go to the VA, to my VA doctor, and was like, hey, can you give me some hydration therapy? They were like, no, go home and drink water. I'm like, come on, like, can you just give me a shot so I could just know that I'm hydrated? So hydration therapy, as Dr. Maisha would probably tell you, is I was told that it's too severe it would be too severe of a process for them to give me hydration therapy. And so I could go in the city and buy a coupon and go to a place that does it, but it's not, I don't want to trust that. But I've attempted to go to my own doctor, the VA hospital, for some hydration therapy. So I think there needs to be some conversations and some policies implemented as we create what we want to produce as results. Is hydration therapy, is it effective? Is it too hard on the body because you got to get an IV when you do that? Like, we need to find out and put some stuff in place, because I just wanted it so I could make sure that at least I know today I'm hydrated and I can, move forward from there. But they were like, no, unless you're going to do a marathon or some kind of strenuous activity, they would offer it to me. And of course I can't do that. So.
Thank you.
KW wants to ask something. Your hand is raised.
Greetings, everyone. First of all, thanks for having this forum. I'm talking to you from the Caribbean. Farron, is really good seeing you. Healthy as usual. I live with Sickle Cell SC,
hey.
And I just
Can
wanted
you
to
increase your volume there, KW, please?
I'm going. Is this any better? I'm going to come closer to the mic. Is this better for you?
Yes. Okay.
Right. Good. So I just wanted to add one thing to the conversation, that we have seen a dramatic change in our health structure globally in less than a year. And we have all these amazing people. We have the European Federation, which are you guys, and we have organizations coming out of Africa, all over the world. How can we get this world to respond to sickle cell? I'm saying now as well that we should have the trait and disease in one conversation, because the trait conditions sound so similar to what we have living with sickle cell disease. So that separation seems to be less and less necessary. How can we get the global medical world to change like they changed in less than 6 months to accommodate for COVID?
So for me, I think in my own opinion, I think we are so fragmented, and what we need is unity for us to bring our voices and work together. We all want do things differently, but the end game is the same. We want sickle cell to be recognized as a public health priority globally. We want the newborn screening program to be implemented universally everywhere. We want proper treatment for sickle cell disease, for sickle cell trait. Now we are working, now this discussion has come up, and we should be fighting for sickle cell trait as well. But one organization cannot achieve that on their own. And the more we get fragmented, the more we are diluting the work we can do together. So we just need to come together, work together, find ways of putting egos and all the other feelings that we have, and just come together for one united voice globally. So the good thing is that there is an SCD coalition that we have Tessa Young here representing, and they represent everybody and all over, and they have a lot of educational research, global issues they're covering. So we can all work with them. But at the same time, we have the newly founded Global Alliance for Sickle Cell Disease Organizations. So we need to support that. We need to all come under that one umbrella. Well, I should be biased because we have the European Federation, but I'm not. I feel that yes, we have the European Federation, but it's regional. It's only working in Europe. But we need to support the global as well, you know, and work together, work with the SCD coalition, work with the government agencies, the policymakers, work with pharma. We need to participate in research. African people or people of African heritage, we are so scared of participating in research, but sometimes it's not all bad, you know, so you just have to know the information and find out what you need to find out before you go ahead. But we need to participate in these things and push our voices further and fight for sickle cell and sickle cell trait now, because the narrative now is for both sickle cell disease and sickle cell trait. That's my opinion. Somebody else might have another one. Thank you.
If I am allowed, I just want to say one quick thing. It seems the regions have different challenges, and if, even though we have several organizations, if a focus can be found in that specialization, so one region deals with universal newborn screening, so everybody comes together under the GASCO, as you mentioned, but we know where the strengths are. We allow them focus on their strengths, but it seems as though regions have different challenges as well. So you focus on the strengths, and we can bring many more issues to the table that are well thought out, well engineered, well activated on a shorter period of time. That's a suggestion on my question based on what you have just shared, ma'am. Thank you.
It is a good suggestion, and I hope that everybody had it and we can work on it. So let's keep the conversation going, KW. More suggestions, maybe even an email. We can send you the ESCF email. If anybody wants to email us, it's office@escffederation.eu. office@escffederation.eu. And we have the president there, Konsi Bomono. We have Jenny Kalea, content management and social media. We have Elvi Ingoli there. She's gonna be working and pushing forward the newborn screening for us. We have Agata Wakunga representing Italy. We have Jenna Diana Baba representing France and also leading on the French Federation for Sickle Cell Organization. And she's also on the GASDO, or the Global Alliance Sickle Cell Disease Organization. So you have many of the people here. And now we have Dr. Kim Smith-Whitley here giving us her huge brain of information to help us through. And we have our special advocate, Dr. Tomia Austin, who has fed us and showed us the truth of what's going on out there that we didn't know. Farron Dozier now, oh God, I think you're gonna get fed up of us coming at you. So yeah, we can work together. And also we have our Director of Health Promotion and Education there. She has a huge task ahead. Elizabeth Koroma there, she spoke earlier. So yeah, we have a huge task ahead. And you have Antonio Arenas there, the co-host, and he's representing Spain. So you have a lot of countries coming together already. So we just need to push it forward and come together and push this strongly. So unfortunately, we are running out of time. I don't know if there are any other questions, quick questions or small messages that anybody you want to say, but we might be closing in another minute.
Hi, Laura. It's Augusta here. I just want to ask one of the doctors, but why is it that some people with sickle cell traits have complications and some don't?
I think that is when you made that statement during your presentation, I said, yes, you have really capsulized what the critical issues are that we need to better understand. Yes. If we knew that, we could focus when babies are born on being able to identify the ones that we know are going to have maybe more problems with this exertional rhabdo. Maybe another is going to have more problems with the spleen. If we understood this better, it would be most informative at the newborn level. I also think that the other thing that you asked about why some individuals with trait have problems and others do not. is the other answer for why sickle cell trait and sickle cell disease advocacy needs to go together. There's so much more if we understood about sickle cell trait that we may understand about sickle cell disease. So why do some individuals with sickle cell disease have problems more with the lungs? Some people have more problems with the brain. And if we brought these two communities together, we can learn from each other.
Okay, yeah, definitely. And some people have problems with their kidneys as well. You know, you were talking about hematuria before, and all of those, they're quite important. And fatigue as well in sickle cell trait, it's all important, you know. And we really need to push this through, because as in public health, when we have better surveillance and more data, all of these things need to embed in one subject, and we need to look at that closely. And sometimes I look at it in a way that is it got to do with genetics? Those people with sickle cell, certain people with sickle cell traits have different genetics that implies that they're having certain illnesses than other people. So all of those things that need to be, lots of research really need to be done.
And I think we also don't have to get over bogged down in the details, and as we need to re-educate the doctors and the healers to say, treat the patient. We will never know every single gene that interacts. My undergrad is in psychology, and we always have this fight in psychology, nature versus nurture. It is both and. It's not versus, it's both and. It's your genetics, it's your environment, it's everything you go through every day. We will never know. We can have two people, we had twins with the exact same genetics, and the difference was the environment, what they were allowed to do in that moment in time. I think we need to stay very focused on developing protocols that will help everyone all the time based on these symptomatic protocols, with the laboratory as a supporting data, but with the understanding that some of these hemoglobinopathies are not going to give you the labs that you want to see. We in medicine, we want to see evidence-based. Show me the lab, show me the number. But we have to begin to remember there's a patient behind those numbers. And so it doesn't always matter. So I think that that's going to be key. We need to have a takeaway from all of this. I'm extremely inspired today that we will work together to develop those protocols. We are stronger together. We are 3 million to 5 million strong, and then all of the allies that are going to support us. And I think that that is where where we will find our hope to go forward with this process.
And it looks like that we have to look into so many areas like nutrition, you know, and it's just given me so much ideas that, you know, nutrition is another big factor when it comes to sickle cell trait and also sickle cell disease. So all of those factors are important.
I've done a health fair one day, and I was there for like 5 hours, and like very few people came to my desk. But when I spoke, a mother came and grabbed her. She called her son from plane and said, "You need to hear his story because it's the fatigue." A lot of people discount fatigue.
It's fatigue. It's just so important. Yes.
She was like, "Listen, tell him your story because he has been complaining for years of him being tired." And my daughter was the same way. I'm like, "Are you lazy? Like, why you come home from school and go straight to sleep?" It's like, what is wrong with you? But when I got into this work, it was like, well, no wonder fatigue. So it's not always pain and crisis. You got to look at, you know, be honest with yourself. And sometimes fatigue is like seems to be one of the top 1-2 symptoms.
Fatigue is a major problem because I have 2 children with sickle cell trait, and I've constantly noticed they are, you know, they're always tired, you know, and you know, sometimes I have to get certain nutrients for them in order for them to boost their energy, and it's a constant struggle with that.
One thing when you're talking about the fatigue, one thing we can do, we have many partners here today that are working on research and are, you know, just doing a fabulous work. So one of the things we look at in research when we're evaluating a disease in medicine is something called QALYs. And it has to do days of your life that are quality. And that's the point. You can't always prevent death, but you can have a better quality of life. And that's a key in trait is people are not looking at the quality of the life of the patients that have trait, which is what you just mentioned with your children. Those days when they're fatigued, they're not studying, they're not getting better grades on their math test, and it impacts their future. So one of the areas that I pray that some of the coalitions that are present that are doing research can look into, don't just look at, okay, do they have end-stage renal disease? What about their quality of life from day to day? And with those 3 liters of IV fluid, which is going to thin the blood better than any oral hydration will do, make a difference with that fatigue. And that's what I mean when I say we need to develop these protocols and treating the patient, because people are having a bad quality of life unnecessarily.
It is. And also it does affect their mental health status. So yeah, we go. There's another protocol there as well.
Wow, this is amazing. I think we could stay here forever, right?
Yeah, we better go. We better pull the plug.
Sunshine to get to, guys.
Fantastic. Thank you very much, everyone. We have a huge conversation ahead for the future. So let us keep the communication open. And I'm looking forward to working with everybody. The Federation is really, really appreciative of Dr. Kim Smith-Whitley for coming on board and giving us that information. Thank you, Dr. Maisha. Wow, you were amazing. Wow, I don't even know what to say. Well, Dr. Tonya Austin, wow, thank you. Thank you, everyone. Thank you, Palmyra, for sharing your story.
Thank
It
you.
really touched me. Thank you, Farron. You almost brought a tear to my eye. Wow, thank you. Thank you, Director Elizabeth Koroma. Thank you for giving that insight. And I have to leave our friend, our boss there, Concy and Antonio, because they are the hosts. So I just had to say my bit. So you go. Thank you.
Antonio, do you want to say something?
Thank you everyone for conversation, for this meeting. I think it's very, very interesting for all. And we are, as said before, Dr. Maisha, we are stronger together. I think it's a very good idea. I think we together, for everyone live in another country, live in another different place, and I think we have the same objective. We have the same objective to reach our goals to survive this disease. Thank you very much.
Yes, thank you, Antonio. Thank you, everyone. I'm really, really glad that we had the chance to have this webinar today. I'm just looking forward to do more, or together we should do more and make sure that we are moving forward and we are actually now in 2021. So before 2022 comes, I think we have done so much, and people, I'm sure, and I know of this, are going to be afraid of what we have started here today. So thank you very much.
Thank you.
Thank you. Everyone. Thank you. Have a good Valentine's. Happy Valentine's in advance.
Thank you.
Happy
Thank
Valentine's Day to everyone.
you.
Thank you so much, everyone.
Amazing.
Thank you so much.
Amazing
Thank
discussion. Thank you all.
Thank you, Concy. Thank you, Laura.
Oh, thank Agathe. Thank you.
Thank you. I'm sorry I don't speak a lot today because I'm not well.
I know.
Okay.
Sorry.
But I understand, and I thanks all of you. Thank you.
Thank you very much.
God give you
Okay.
healing, my sister.
Bye. Get well soon. Bye.
Thank you to all the doctors, amazing team. Thank you so much.
Thank you.